Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat webinar. This evening, we're going to be sharing with you an algorithm to improve patient comfort and reduce and treat diabetes mellitus-related cirrhosis. As speakers this evening, we have Dr. Shasha Hu, who's Associate Professor at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, Director of Aesthetic Dermatology, member of the Skin of Color Division, University of Miami Miller School of Medicine in Miami, Florida, and co-founder of BeALife. We also have Dr. Robert Kirshner, who is the chairman and a Harvard Blank professor at also the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, professor, Department of Public Health Sciences Director, University of Miami Hospital and Clinics for Wound Center at the University of Miami Miller School of Medicine in Miami, Florida. We'd like to thank our sponsor this evening, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit the question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill in the questionnaire and send it back to us. Also, within 1 to 2 days of the webinar, the recording will be sent to you automatically, as well as a certificate of attendance. Again, if you want to ask questions to our panel, please type in the questions in the question chat pane on the right-hand side of your screen, and I wrote a little note there so you can see where you have to type it in. So without further ado, I will pass the floor virtually to Dr. Robert Kirshner.
Well, thank you, Roxanne, and it's a great privilege to be here today and share this information about our about diabetes related cirrhosis. Let me see if I can get this. There we go. So we're going to start with a polling question. And which of the following is false? And please select one. Diabetes causes thinning of the epidermis. Diabetes causes skin dehydration. Diabetes causes skin inflammation. Diabetes causes more transepidermal water loss, or none are false. Okay, great. So we have an opportunity for some learning today, so that's great. And I'm going to go through, and you'll see in the presentation the correct answer as we go forward. Oops. So the background of the project that we're going to discuss is that maintaining intact skin barrier by preventing and treating cutaneous cirrhosis may improve skin conditions in patients with diabetes. Currently, gentle cleansers and moisturizers are underutilized, and skin care is frequently lacking or overlooked as part of a patient's prevention and treatment. And to address these unmet needs, we were part of a project, Dr. Hu and I, for preventing and managing diabetes-related cirrhosis using gentle cleansers and moisturizers. The project was developed to improve patients' quality of life by offering tools for preventing and managing diabetes-related cirrhosis using gentle cleansers and moisturizers. And we wrote a review paper in 2021 about this that was recently published. Furthermore, a multiple investigator-initiated international cohort, which had included 528 patients using a gentle cleanser and moisturizing cream, showed improvement in skin conditions in patients with diabetes-related cirrhosis. And therefore, we took this background material of the review paper of this study and created a practical algorithm for preventing and managing diabetes-related cirrhosis. So what are some of the challenges of management of diabetes-related cirrhosis? Well, as I mentioned, we published some of the diabetic skin changes in this review published in the Journal of Drugs and Dermatology back in 2019. That serves as a great background for this. And without going into great detail, I just want to summarize that we know that diabetes is a common and debilitating disease that also affects the skin. In fact, probably 30 or 40 million Americans each year have diabetes, overall have diabetes. Of those patients with diabetes, somewhere between a third and 70% of patients present with skin conditions, and it can vary in severity, maybe benign or maybe deforming and even life-threatening. And we'll discuss some of these in the next 15 or 20 minutes. These skin conditions can often insight into a patient's glycemic control, and in some patients, they may be the first sign of diabetes in undiagnosed patients. And it's important to recognize and manage these conditions to improve both the patient's quality of life and also by recognizing their diabetes, avoiding future serious adverse events. Now, what other things do we know about diabetes-related skin changes? Well, the mechanism of action of diabetes-related skin changes is unclear, and there are probably many factors are involved. But we do know that hyperglycemia does contribute to skin changes. And in patients with diabetes, the functional properties of the skin, especially the stratum corneum, are altered, which impacts functional skin barrier and could lead to many, many skin changes and adverse outcomes. Now, this was the question that was posed in the poll, and what's known through a series of work over the last 25 or 30 years is that skin hydration is decreased in patients with diabetes, and this is because there's an increase in transepidermal water loss, an alteration of certain skin proteins such as filaggrin, and this abnormal skin barrier leads to increased inflammation of the skin. Interesting, even though there's increased transepidermal water loss and a decrease in skin hydration, the cohesiveness of the epidermis is altered. And in fact, the epidermis is thicker than normal. So you have a thicker but abnormally functioning epidermis in patients with diabetes. Now, what is the impact of this on skin barrier function? Well, the most common changes in patients with diabetes are xerosis and acquired ichthyosis, and it often is localized to the lower extremity, often the lower legs and feet. And in fact, moisturizers can improve the feeling of well-being for patients with diabetes. Now, keratinocyte homeostasis is impaired in patients with diabetes, and the epidermal barrier function is abnormal in both direct and indirect mechanisms, and puts these patients at susceptibility to many problems that I mentioned, including xerosis, chronic wounds, and infections. And this can increase dermatologic comorbidities of diabetes. And in addition, a long-standing hyperglycemic condition impairs the skin barrier and accelerates the skin aging process. So what are the things we see clinically? Well, some of the earliest skin changes that we may see with diabetes is certainly xerosis, and we're going to focus on this throughout the talk. And as a consequence of xerosis, oftentimes patients with diabetes are pruritic. They may have the diabetic foot syndrome, which we'll dive into in a little bit. And they also may have ichthyosiform skin changes as a severe manifestation of xerosis, as well as keratosis pilaris, which we're not going to speak about specifically in this presentation. So let's talk a little bit more about diabetes-related xerosis. As I mentioned, because of the ultrastructural, electron microscopic, and physiologic changes in the skin of patients with diabetes, xerosis is the clinical outcome. And it's very common in patients with diabetes. It results from this abnormal, persistent cohesion between corneocytes, which, as I mentioned, leads to a secondary thickening of the stratum corneum and a thickening of the epidermis. This leads to impaired moisturization of the uppermost stratum corneum layers, increased transit time of the corneocytes in the stratum corneum, and as a result, altered skin barrier function. And you can see this finding both clinically with xerosis, and it's also correlated with the microangiopathy associated with diabetes. And we know that the microangiopathy seen in diabetes occurs over time, and therefore the diabetes-related xerosis seems to get worse with time and diabetic control. This is a cartoon of this epidermis comparing normal skin in the middle and the xerotic skin in diabetic that they may present with scaling, pruritus, and fissures. And you could see that there's reduced cohesion of the dermal and epidermal layers and thickening of the stratum corneum, leading to a thicker but dysfunctional epidermal barrier in the patients with diabetes. So how do patients with diabetes who have this epidermal changes present? Well, oftentimes they may have a feeling of skin tightness, especially after their skin gets wet, showering, bathing, and swimming as examples. The skin appears shrunken or dehydrated. The skin feels and looks rough rather than what it should normally look smooth. When the skin gets dry and tight and rough, oftentimes the consequence is itching and pain that may be mild to quite intense. Scratching may ensue that may lead to patient-induced redness and inflammation, or may occur as a consequence of abnormal barrier function. You may see a variety of severity of slight to severe skin peeling and scaling, fine lines, cracks, and fissures, and even deeper fissures that may bleed in most severe cases of xerosis. So when we see a patient with dry skin, it's a good idea to assess their general health to make sure that they don't have other dermatologic or systemic problems. Assess their throughout their body for scaling, itching, pain, redness, fissures, and that will lead you to a treatment algorithm we'll talk about in a little bit, and hopefully to improvement of their skin condition. Now, there is a functional classification of xerosis in patients with diabetes, taking into account rough and scaly skin, the presence or absence of itching, pain, redness, and fissures. And as you go from the absence or mild manifestations to more moderate manifestations to severe manifestations, you can then classify patients with mild, moderate, and severe dry skin. And in that 528 patient study that we carried out, we used this tool to classify patients' diabetic severity and their improvement with intervention. So one of the major manifestations for patients is pruritus, which affects their quality of life. Oftentimes, pruritus is considered it has the same effect of quality of life as pain, and pain is considered the fifth vital sign. It may affect specific areas such as the scalp, ankles, feet, trunk, or even genitalia. And while it's not understood, certainly a number of different mechanisms are at play, including neuropathic changes that are seen in diabetes. We know that several studies have been undertaken to look at pruritus and xerosis, and we know in this cross-sectional study of 120 patients with diabetes, those with skin xerosis had more advanced pruritus than those without xerosis. And the mean itch quality of life score was assessed that suggested that itch, in fact, does impair patients' quality of life and is associated with pruritus intensity. The more intense pruritus, the more detriment in patients' quality of life, and this is correlated with xerosis. And patients, as I mentioned, who are pruritic and diabetic often have dry skin or diabetic neuropathy. Pruritus is, as I mentioned, is more likely in patients who have xerosis and neuropathy. It may often be localized to areas I've already discussed, including the genitalia and intratiginous areas, as well as the feet and lower extremity. Although I'm not going to focus on pruritus per se, certainly a number of different treatments can be used based on whether or not there's secondary infection, whether or not they're localized, where topicals may be used, or whether or not systemic agents may be needed to treat patients with this diabetes-induced pruritus. So the common locations where you may see this xerotic and pruritic skin, often on the feet, the legs, the trunk and genitalia, and coupled with peripheral neuropathy, this sets up a bad scenario where patients may in fact develop excoriations and secondary infection, which in diabetics can have severe consequences. We also know that in addition to xerosis and pruritus, oftentimes patients with diabetes have cracked heels. This is often due to prolonged standing, especially on hard floors. And we know that most of the diabetics we see, probably 90%, are overweight, and this increases the pressure on normal fat pads that may increase the risk of heel cracks in this population. The skin is not supple because of autonomic dysfunction of the skin, which I'll talk about in a moment. Oftentimes it's made worse by open back shoes, which will increase the pressure on the feet, leading to cracking and fissuring to even a greater extent in this population. Once you get this dry skin, and if it's cracked or fissured, you're at an increased risk of infection. But it turns out there are other reasons why patients with diabetes are at increased risk of infection. First is that the normal acid mantle of the skin is less functional. Oftentimes, patients, the warm, moist environment caused by footwear may cause maceration and put patients at risk for infection, especially fungal infections. Fungal infections may lead to microscopic or even clinical cracks and fissures in the skin where bacteria can enter, and this can be accompanied by a secondary cellulitis. Now, this is especially important in patients with diabetes who have the diabetic foot syndrome. And we know that a major consequence of the diabetic foot syndrome is diabetic foot ulcers, which is really a global pandemic. Places all over the world that can least afford to have increased risk of diabetes and diabetic foot ulcers, Africa, Asia, have nearly a doubling of the diabetes rate over the last decade or so. Once you have a diabetes, you have up to a 1/4 to 1/3 risk of developing a diabetic foot ulcer during your lifetime, and patients with one diabetic foot ulcer develop a second diabetic foot ulcer very, very commonly. Unfortunately, if you have a diabetic foot ulcer, this portends a poor prognosis because every 20 seconds throughout the world, their lower limb is lost to diabetes. 85% of amputations are preceded by diabetic foot ulcers. They're slow to heal, and the 1-year amputation rate in patients with a diabetic foot ulcer is approximately 15%. Beyond the patient-oriented outcomes, this is a huge expense both to the patient and to health systems across the board. Now, just putting this in perspective and bringing it back to the pathophysiology of foot ulcers, you can see that peripheral vascular disease and sensory neuropathy also are critical in causing diabetic foot ulcers, but you also notice on the far right, patients with diabetes have autonomic neuropathy, which plays an important pathogenic role in the development of diabetic foot ulcers. When diabetic foot ulcers occur, they often occur at highest risks on the toes and the heels, and oftentimes they're not even recognized because the patients are insensate and may not even know that they have a wound. Oftentimes, repetitive trauma will lead to a callus, and underneath that callus or hyperkeratotic lesion on the diabetic foot, a wound will be manifesting. And only through close inspection and care of the diabetic foot can you pick up a callus and perhaps an underlying diabetic foot ulcer. That's why examining and taking care of the feet, moisturizing the feet, can be a critical element in early recognition, prevention, and treatment of diabetic foot ulcers. Diabetic foot ulcers certainly, it takes a multimodal approach, an interdisciplinary team both of wound care doctors, vascular surgeons, podiatrists, and dermatologists. But remembering to take care of the skin, both as a prevention and as a treatment, is going to be critical in preventing this unwanted complication. And just to bring this whole thing back home, again, we started with the idea of this functional barrier problem in patients with diabetes and ways that we can address this. And patients with diabetes who are at risk for all of these complications can benefit from skin care. The skin care that can be provided can reverse the impaired skin barrier function, reverse the increase in transepidermal water loss that we've discussed already, and improve patient skin with diabetes. And by using certain treatments that you're going to hear about in a moment from Dr. Hu, you can actually restore the complex of cholesterol, fatty acids, and ceramides that normally make up the skin but are abnormal in patients with diabetes. So proper skincare using the proper moisturizers can reverse and prevent the complications of diabetic foot ulcers. So I want to stop here and just summarize that applying moisturizers for these at-risk patients can not only improve the well-being of patients with diabetes, but can prevent and treat the skin changes, whether it's mild or the most severe skin changes we see in patients with diabetic foot ulcers. So with that, I'd like to stop here and turn over the virtual mic to my friend and colleague, Dr. Shasha Hu.
Thank you, Dr. Kersner, for that wonderful introduction and summary on diabetes-related skin changes, which gives me the perfect leadway into the second half of tonight's Skin Chat, in which we'll be talking about key studies on supporting the benefit of a topical skincare regimen that can improve the quality of life in patients with diabetes-related skin changes. So let's start with the polling question. Which of the following is not recommended for patients with diabetes-related cirrhosis? A, antimicrobial cleanser to minimize bacterial colonization. B, daily moisturizer containing lipids to restore barrier function. C, moisturizers with urea or salicylic acid for keratotic areas. D, visual inspection of feet for skin breakdown signs of ulcers. Or lastly, referral to specialists for persistent erythema, pain, or itch. So which of these is not recommended? And we'll find out the answers. Oh, perfect. I see that we have a very knowledgeable audience today. Which will make my job a lot easier as we present our key studies on diabetic skincare. Okay, 1 second, let me advance forward. Okay, perfect. So I'm going to start with the practical algorithm that just got accepted for publication that Dr. Kersner mentioned a little bit earlier. We wanted to develop an algorithm for clinicians and healthcare workers who treat diabetes patients with skin changes. Really want to develop a guideline that's easy to understand and can be used to prevent and treat early diabetes-related cirrhosis and symptoms such as itching and pain and fissure. And we want to focus on topical over-the-counter skincare regimen only, and then conditions that relate to diabetes that require systemic treatment such as diabetic foot ulcers were outside the scope of this publication. So this publication was again briefly mentioned by Dr. Kersner earlier in the talk tonight. I'm going to first go over how we developed the algorithm. We first select a panel of experts. So Dr. Kurz and I are both very honored to be part of the panel. We performed an extensive literature review on skincare relating to the care and prevention of diabetes-related cirrhosis. We then met in person to design an algorithm that can be used for clinicians in treating, educating, as well as preventing diabetic related cirrhosis. And the algorithm were voted through blinded voting system, and then final algorithm was published and accepted just very recently. For our literature review, we basically looked at over 11 years interval of publication in the English language, we wanted to select high quality publications, mostly focusing on grade A or B studies. So these are studies that were either double-blind randomized controlled trials of high quality or single-blind randomized controlled trials. Unfortunately, that is also an interesting point. While we looked at data from the past 11 years, what we found was that there was a very limited numbers of publication on diabetes-related skin changes and skincare addressing this issue, because from January 2010 to September 2021, there were only 197 publications in the English language, but we had to exclude a majority of them due to either poor quality or duplication. So only 54 studies met our selection criteria. So we were not able to grade the studies based on the grading system of A, B, C, or level of evidence 1, 2, 3, 4. However, we're able to include 8 systemic reviews, consensus, and guidelines, and 19 clinical studies, 23 reviews, and 4 book chapters for our literature review portion of our development of algorithm. As you can see, Dr. Kersner already presented a few of the key systemic reviews in his part of the talk tonight. And so I'm going to spend a little bit of time on this slide, because this slide, it really represents the final practical algorithm that we agreed on and felt very confident that it will be very beneficial for any clinician treating patients with diabetes-related cirrhosis. So as you can see, this diagram is a bit busy, so but I can walk you through it. As you can see, that the foundation of caring for diabetes-related cirrhosis, whether it's mild or moderate or severe, the foundation includes education and behavior measures, such as a control of blood glucose and HbA1c level, educating on patients on avoiding skin irritation, proper skincare, including daily sunscreen, in daily inspection of their feet, especially if they're at risk for diabetic-related foot ulcer if they have neuropathy. Also educating patients on proper clothing, such as loose cotton clothing, proper shoe wear, such as avoiding wearing sandals, proper orthotic support if needed. So this is the foundation of triaging patients with diabetes-related cirrhosis. But then also when you look at our algorithm, which is stratified by clinical severity, so we have a pathway for those patients with diabetes, but mild cirrhosis. So they have a little bit dry skin. They may have just very mild occasional itch or a little bit redness. And then we also develop an algorithm for patients with a little bit more severe cirrhosis, those with a more rough texture, a little bit more pruritus. They may even have pain from dry skin. And then final category are those patients with severe cirrhosis. So they may have pain, erythema, or even fissures of the heels, and then can predispose them to diabetic foot ulcer. So as you can see, for each 3 decision names, all of them share a basic skincare regimen. So for body, we recommended using gentle cleanser, so not harsh cleanser, not antimicrobial cleanser, but gentle cleanser and moisturizers containing lipids to restore and protect skin barrier. And I will show some key studies that support the application of moisturizer containing lipids shortly. And then for patients having facial dryness, we'll recommend, again, gentle cleanser, moisturizer containing lipids, but also moisturizer that are non-comedogenic to avoid clogging of the pore. And lastly, for key acrocytes, hands and feet, where patients with diabetes have a little bit more severe cirrhosis or dry skin, in addition to combination of gentle cleanser and lipid-containing moisturizer, we also recommended inclusion of over-the-counter moisturizer with urea or salicylic acid to provide a little keratolytic effect for the heels or the soles of the feet where their skin is a little bit thicker. So this is important for patients with moderate cirrhosis. They may have some itching, they may have some pain. We also recommend that when patients have a little bit more severe cirrhosis, when they start having signs of cracking of the skin, when they have fissure of the skin, we recommend, in addition to all of the above mentioned skincare regimen, consider incorporating colloidal dressings such as Duoderm, skin glue or liquid bandage to protect the opened or fissure skin to promote wound healing. But if patients do not improve, especially for patients with severe cirrhosis, if they're not getting better with daily skincare that includes gentle cleanser and moisturizer using with lipids, then it's time to consult with a specialist, potentially debride the callus, debride the wound, and also if they have further progression of the symptoms, then this is a time where we may consider recommendation of further treatment such as oral therapies, oral antibiotics, or topical steroids, which are beyond the scope of this algorithm. But looking at this chart, as you can see, the common theme that we recommended for patients with diabetes-related cirrhosis is really simple. Good skincare with gentle cleanser and a topical moisturizers that can help to restore skin barrier, ideally a moisturizer containing lipids. And why lipids? So as Dr. Curzon showed a little bit earlier in the evening, lipids are actually a very important component of our stratum corneum, particularly the bilipid layer that protects our skin from the external environment. And when we look at the components of extracellular lipids in the stratum corneum, as you can see, ceramides actually make up the majority of the lipids, followed by cholesterol and free fatty acid. So this is the ratio that's almost like the ideal ratio that we recommend for healthy stratum corneum. But this ratio may fluctuate based on host condition or external environmental factors. So for example, in drier conditions, when the winter, when you turn up the heat, or patients have inherent disorders such as eczema or ichthyosis, this ratio becomes disturbed and the ceramide levels of affected stratum corneum become lower. When that happens, a cascade of reaction ensues. For example, when the ceramide levels are lowered, we typically see an impaired skin barrier function that leads to impaired barrier homeostasis. And then clinically, that leads to dry skin, and then that can also progresses into inflammation. So that translates to erythema or red skin, itchy skin, and then that leads to maybe exacerbation of the itching if the patient starts to scratch, and then this really turns into a vicious cycle that can escalate quickly to cellulitis or diabetic dermopathy or other complications that Dr. Curzon mentioned earlier, particularly in patients with diabetes when they're prone to bacterial fungal colonization. So it's important to maintain the ceramide level in the skin. So in addition to these inherent factors, we also know that even as simple as water pH can affect our skin pH, and that can in turn affect the composition of our stratum corneum lipid level. So for example, our normal skin is happiest at a slightly acidic pH. So we say usually 4.7, but the range can fluctuate between 4 to 6. That's considered the healthy skin pH, also known as the acid mantle. But we use tap water to wash our face, cleanse our body. That's already slightly higher pH than the normal skin pH, typically at 7 to 8.5. But then when we add harsh soap, that further strips away our skin pH and can change our skin barrier function. And when the skin pH increases, a cascade of reactions such as increased inflammation, decreased stratum corneal cohesion, as well as decreased level of lipids in the stratum corneum, then that leads to decreased skin barrier function, increased skin permeability to irritants. And then this is a very important cycle to keep in mind when we talk about maintaining skin integrity. So we need to think about not only barrier function, but also skin pH. No, so how do we incorporate skincare that can protect a skin pH and restore skin barrier function? In our previous skin chats, we talked about the main types of skin emollients. As you recall, there's the occlusive emollients, emollients with occlusion and humectants. But tonight, we're going to focus on emollients with the most elegant design. So these are emollients have both humectants, such as hyaluronic acid, to help to maintain hydration or increase skin hydration, as well as physiological lipids to help to restore normal skin barrier function. So in this system, we have a restoration of the skin barrier in addition to increasing skin hydration. And when we look at the CeraVe technology, what is most interesting about CeraVe technology is their multi-vesicular emulsion system. So MVE is their patent system in which the moisturizers are formed with a series of concentric spheres of oil and water phases. So as you can see this diagram, as we apply a moisturizer with this MVE system, the concentric spheres of water and oil content releases layer by layer, so gives a sustained release after application, in contrast to traditional emollients that lack the MVE system, in which you have a burst of release of hydrating ingredients. You don't have the sustained release. And I'll show you shortly on studies that validate the benefit of the MVE system and why it's important to take that into consideration, especially when you have patients with diabetes-related cirrhosis. And also want to mention that in addition to the slow-release MVE technology, CeraVe moisturizer and cleanser system all have a lot of key important features that are safe and gentle for all skin types. They're fragrance-free, hypoallergenic, and they all have key ceramides, ceramides 1, 3, 6, and 11. They're important for maintaining skin barrier. And also additionally, many of the CeraVe components are lack of potential irritants such as sulfates, propylene glycol, and parabens. Now I'm going to go over two key studies that demonstrating the benefit of ceramide containing skincare. First is the study that Kursner mentioned a little bit earlier, which is literally hot off the press, is a multi-center international study that enrolled adults with both type 1 and type 2 diabetes. And the objective of this study is to evaluate the improvement of cirrhosis in patients with diabetes following a twice-a-day ceramide-containing skincare regimen. Patients were given CeraVe hydrating cleanser and moisturizing cream. They were asked to use on their body twice a day, focusing on extremities, and patients were seen 3 times in the study: a screening visit, a baseline day 0, and then after 28 days of application. When we looked at this study was quite impressive in the sense that it enrolled over 500 patients from 19 countries and a very diverse population. These patients had cirrhosis from diabetes. As you can see, the most common area of cirrhosis were extremities, legs, feet, arms, and hands. Very similar to probably the general population of patients with diabetes. When we look at the data, I think I was most impressed with the high compliance rate of this study. study patients were reported to be over 80% were complying with the twice daily application. So this translates to clinical feasibility, real world feasibility, especially when you take care of patients not enrolled in clinical trials. So this is very important. And even for patients who were not 100% complying, was found that the rate of missed dose was quite low. It was less than 10% of expected application. And then when we look at the primary efficacy endpoint, this is physician scored global aesthetic improvement scale. As you can see, over 98% of patients either improved or very improved or very much improved from baseline when assessing cirrhosis. And then when they used dry skin scale, as mentioned earlier in the talk, again, majority patients had at least 1 point or 2-3 points improvement in texture, erythema, and fissure related to diabetes and dry skin. And similarly to clinician scored primary endpoints, patients also reported significant improvement in dry skin scale with over 90% improvement in all parameters. And when we look at quality of life, so this is very interesting. Dr. Kurza mentioned a little bit earlier about how diabetes cirrhosis can affect quality of life. As you can see at baseline, people are embarrassed about having dry skin. Dry skin from diabetes affected social as well as work life. But as you can see, at the end of 28 days, all parameters improved. So significant improvement in quality of life, which means that what we do for patients not only improves their skin, but also improves their mental health, which is a really important aspect of patient care. These are clinical pictures showing typical improvement in the degree of cirrhosis in this study. So in summary, this multi-center international study of diabetes patients with cirrhosis using a twice a day application of a gentle cleanser and ceramide containing moisturizer found clinically significant improvement in both cirrhosis as well as dry skin scale. And then in addition, there was a significant improvement in quality of life in these patients enrolled in the trial. So validating that we can definitely improve cirrhosis from diabetes, and we can help patients to feel better about themselves, especially when we talk about diabetes-related cirrhosis. I'm going to go over two more studies further demonstrating the benefit of using lipid-containing moisturizer. So in this study, the study enrolled 49 women with dry to very dry skin. Interesting, in this study, patients were asked to use the moisturizing cream twice a day on one leg and did not apply moisturizer to the other leg. Biochemical studies were collected at end of 28 days and then after 48 hours for regression study. As you can see, there is a significant improvement after 4 weeks of application in skin barrier. And then interestingly, the improvement maintained after 48 hours. And then we talked a little bit earlier about the importance of a skin lipid. So in this study, biochemical exploration found that there were significant increase in ceramides, again, maintained improvement after 48 hours of stopping application, demonstrating the benefit of the MVE system or the slow release system. In addition to ceramides, were increased level of cholesterol as well as free fatty acid. And visually, patients also improved significantly. As you can see, a patient with a very dry skin, patient with average dry skin improvement at 3 days, week 4, and at 48 hours of regression. So in conclusion, excuse me, my mouse is acting a little bit up sorry, I apologize for that. I'm going back. Okay, so in conclusion, although diabetes-related skin disorders are very common and consistent, but there is very limited data on how we treat and prevent early stage skin conditions in diabetes patients. But we know that if we can prevent and educate, increase awareness on early diabetes-related skin conditions such as cirrhosis, pruritus, we can significantly reduce morbidity of patients with diabetes. And we have shared with you studies that show that there are definitely benefits in incorporating gentle skincare and moisturizer containing lipids to improve early stage diabetes related cirrhosis. And of course, at the end of the day, it's important to continue to spread awareness about diabetes related cirrhosis, and by spreading awareness, educating our patients, we can make a significant improvement on quality of life change in this population. So thank you for your attention.
So we'd like to remind you, if you want to submit questions to our faculty, please use the question chat pane on the right-hand side of your screen. And if you think of any additional questions following this webinar, you can always send them to info@rbcconsultants.com. We'd also like to thank our sponsor, CeraVe, for making this educational event possible. So we'll go to questions from our audience. The first question is it safe to have diabetic patients apply moisturizer between the toes?
I'll take this one. So this is a commonly asked question. Normal patients, yes, patients without diabetes will benefit from moisturizer in between the toes, but as Dr. Kirshner presented earlier, diabetic patients have compromised skin barrier, particularly against various fungal and bacterial colonization on the skin. So we don't want to moisturize that web space that can potentially become macerated, and then that can increase risk for tinea pedis or candida. So moisturization should be focusing on the dorsal and the heel aspects of the feet.
Can you give an example of a skin disease where the duration of diabetes might be known?
I'll take this one, Shasha. So yeah, a good example is oftentimes I'll walk into a room, and when I shake a patient's hand, I'll put my other hand on their upper back. And just by shaking their hand and putting your hand on the upper back, you can diagnose a condition called scleroderma, which is not scleroderma, but scleroderma, which is a mucin deposition in the skin. And we know that scleroderma usually occurs after a prolonged time of having diabetes and having glucose control that's imperfect. So just by walking into the room, being friendly and saying hello, you can make a diagnosis of long-standing or uncontrolled diabetes in a patient. So that's one example of how a skin disease can tell you that a patient's had diabetes for quite a while.
What do you recommend specifically for non-diabetic male atopic young adults with thumb and fingertip deep fissures? So a little bit off topic, but relevant.
For fissures over the knuckles, is that?
Thumb and fingertip.
Oh, thumb and fingertip. Okay, that's actually a good question. First, we want to kind of do a query of lifestyle. A lot of my patients with similar pattern, they have hobbies that predispose to very repetitive mechanical injury to the thumb or the fingertips. We also want to eliminate harsh skincare products such as harsh soaps. And then a lot of times, once it develops a fissure, super glue or liquid bandage are very helpful because that will really allow the acral area to heal faster, because we know acral areas are slow to heal as the stratum corneum takes much longer to regenerate.
Are there examples of glycosylation of the skin similar to HbA1c?
Yeah, so people have said that a lot of the complications from diabetes are due to age, advanced glycation end products, or AGE. And the one that we measure most commonly is the hemoglobin A1C, and that tells how long the red blood cells, how they've been glycosylated, and if they're exposed to a lot of sugar in the blood, they become more glycosylated, and the hemoglobin A1C is abnormal and high. But other structures in the skin or right below the skin can be glycosylated as well. And one example, which is nice to know and kind of a cute thing, is oftentimes the tendons of the hands can be glycosylated. And normally, if you're healthy, you can put your hands together like that. But if you get glycosylation of the tendons, you can't put your hands together, and you get a space. And that's called the prayer sign, also called chiroarthropathy. So if you ask a longstanding diabetic who has poorly controlled glucose to put their hands together and pray with you, you can get a sense of, that they have poor glucose control because they get glycosylation of their tendons. Another example is when we measure the blood flow of the legs. We usually do an ankle brachial index. But if the blood vessel, the arteries get glycosylated, you can constrict them when you apply the blood pressure cuff, and you can have a falsely normal or a falsely elevated ankle brachial index, and you have to do other testing like pulse volume recording, send the patient to a vascular lab. So these are all kind of very practical clinical examples of advanced glycation end products that dermatologists and other physicians may come in contact with.
When do you add topical steroids for itchy and dry skin in diabetic patients?
Okay, great question. So going back to the practical algorithm that we just presented, we really want to start with the basic skincare first. So a lot of mistakes practitioners make is to throw on topical steroid without even talking about moisturizer, things that we can restore skin barrier. So after you implement a good skincare regimen and the patient is still itchy and there is erythema, and then it's time to add a topical steroid. Typically, I like to use something a little bit more potent, class 2 or 3, kind of throw at the skin. So don't waste your time with a hydrocortisone. That's not going to be effective enough. So use something like triamcinolone, clobetasol to decrease the inflammation. But after 2 weeks application, if patients are not better, then you need to reassess and going back to the algorithm, see what's missing, and make sure we're not missing any signs of the infection, make sure we're not missing any potential contact dermatitis if the patients don't get better with a topical steroid in addition to a skincare regimen.
Does the diagnosis of diabetes precede the skin complications?
Oh, I'll take this one, Shasha. So if I interpret the question right, I think the question may be talking about, can you see a patient not know they have diabetes and see that they have skin problems that look like diabetes? And it turns out that actually it happens, unfortunately, much too frequent. I kind of use a number, over 30 million Americans have diabetes, but probably about a quarter of them don't know they have diabetes. They have undiagnosed diabetes. And oftentimes they will present with the complications of diabetes even before they know they have it. So they'll come in with renal insufficiency or renal failure. And they say, well, somebody will ask, do you have diabetes? They'll say no, but when they're tested, they'll be shown to have diabetes. And the same thing is with the skin. So I think it's very important when you see a patient who has some of these skin changes that are associated with diabetes, whether it's something like xerosis or pruritus in certain locations, the scalp, the genitalia, the lower extremities, or more classic findings such as necrobiosis lipoidica or sclerodema that you specifically assess for diabetes because they may not know they have it. And by determining and finding that they have diabetes, it makes the dermatologist role pivotal in allowing not only to take care of their skin, which of course is important, but also maintaining their general health in a much more efficient manner and getting them on treatment sooner rather than later before complications can ensue. So so be on the lookout, even people who don't know they have diabetes, because diabetic changes can occur in the skin and other organs.
And one final question, can you give an example of a skin disease where the duration of diabetes might be known?
Oh, I think Dr. Person may have.
Yeah, I think I might have
Oh,
mentioned
you
that when
did?
it was
Oh, I repeated it twice.
edema,
So
yes.
that's all the questions we have for this evening. But we'd like to thank Dr. Hugh and Dr. Kirschner for having developed this wonderful algorithm and educating us on it so that, you know, we can help diabetic patients. And we'd like to thank you all for joining us this evening. Good night, everybody.
Bye. Good night.
Good night.